close enough here, and suppose we should call the meeting to order. Did everyone get a chance to review the minutes? And if so, entertain a motion to approve. Second? All in favor? So, for those of you that don't know me, I'm Matt Talbot. I'm the ER director at Finger Lakes Health, and Dr. Davidoff is on a beach somewhere in the Grenadines, so is not around for our 72 hours of victimization by somebody probably over in the Netherlands or Russia, or we're not really sure where. But it's been a challenging few days, but I'm glad to be here. So I guess the next item on the agenda is standing reports, interim program agency coordinator.
I'll do part of it. I have under old business a conference, but we'll touch on it under this part of it. The conference was held the last Friday and Saturday of February. It went very well. We got a lot of the good favorable things on the conference back. Ross was there and did a presentation, as did many others. We got some feedback as to some other things that they would like to see presented again. And also some of our short little snippets, they asked if we could start bringing them back for some longer time for regular CMEs. Excuse me. So that will be something that we'll be working on. The big discussion was, do we want a guest speaker, or do we want to do go back the way we just did it and do the little breakout sessions? And I think the consensus was from the conference committee is we will stick with the way we did it this year, so we can do more offerings and that type of thing. So it did go very well. We didn't really have any major glitches. So speakers, we had to switch a couple around. Dr. Supple was ill at the last minute. Dr. Davidoff filled in for her lecture or two. Dr. Vernetti had to switch out with Dr. Davidoff because she had a prior commitment in the afternoon when we had scheduled her. So, but overall it went very well. And probably by fall I will be after all of you again to volunteer, or not volunteer, but to be part of it for next year. So, Nate, you want to add on the conference?
We got overall the conference very well. We had a lower attendance than we've had in the past. This coming year, we're going to try to put out a bit more advertising starting earlier, using a lot more social media. So we're trying to get the classes and everything lined up now, so we can actually start advertising that, and then worry about getting our speakers afterwards. So.
We did chat about it. I do think attendance is down a little bit over previous years and that because so many agencies belong to the CME program and they have their online learning that they already pay for, so they're less apt to send someone to the conference, or if they allow them to go to one conference a year. Vital Signs has been closed the last 2 or 3 years, either between Syracuse or Rochester, so some of them have gone to that, which is fine. But again, and we're seeing more and more of the day things. Thank God for Mercy Flight that they do their day education thing, but they also offer them in Syracuse and they offer them in Skinny Atlas and that. So there's a lot more day EMS programs going on for people to catch as well. So I think we're getting the stuff out there. So we'll see. Short of going around picking them up and driving them to it. But I think it went well.
Very good. Are you up again here, Donna?
I guess I am.
Okay.
Nate, did you want to add anything on program first?
The IO study is wrapping up. We're ending our fiscal year here in a couple of months. One of our deliverables is a focus study, which was the amount of female-led IOs versus stipulated placements. Survey is going to be going out to the 14 agencies that put IOs in the last 6 months. We had a NOS study, a Measure Access study, which is going to be the next year's project. Ken and Mr. Hag here probably give you a little more information on the cost of that and the possibility of doing that. Turn it forward with that for a second.
We looked at some nitrous as from our supplier, Airgas, and got the plan put together, and Ken has the price, which is a little bit of a hiccup if I
We're looking into a couple of different options. The most readily available system is the Nitromax system. Cost for each of the mixers is, list price is $3,700 a piece. We've been able to negotiate a price down to about $2,600 a piece. So that's just for the mixer. The air gas is still trying to figure out exactly what it would cost to rent each tank. They won't sell them, obviously, so
And we need 25 units for the region.
25 units and I think 50 tanks is what we kind of came up with for numbers. So it's not going to be a cheap undertaking.
And is that the region's going to pump that with costs, or the agencies that wanted it for?
That's the question. There's no money in the region. So,
There's no money in the agencies. So.
there's no money in the region.
Other than that, it's all sounds great.
One of the other projects we're right now is just going to go through policies and procedures within the region. There's a little spreadsheet that's untitled, floating around. The list there shows charts that were closed outside the 24-hour window, which was established by the region many years ago. Percentages are on the right based on total calls for the year since January 1st. What we're going to do is just send a letter out to the agencies reminding them that they need to have their charts closed in 24 hours. They have 30 days to be in compliance with that. We'll run the report later on. That letter will also include information that we'll be checking the 911 centers just to make sure that all calls that have gone out do have charts attached to them, because that's one of our deliverables as well. That's all.
So moving on, spring EMS classes are up and running, obviously. Summer classes have been set. They'll be advertised out this week. They'll be here on campus. We are getting ready for our senior paramedics to test out in May. They're on the countdown. Their clinical and ride time, the clinicals are all done. Their ride time, they have until the 21st of April to get all of their capstone done. Many of them, or several of them, are already done at this point in time. And then it's now into the review phase for them so that they can test in May. The new class that started in January on Martin Luther King Day came in with 29 students, so it is a large class, which is okay. And they seem to be progressing along. We started IV therapy with them last night, so we'll see how many hit the floor when we start poking each other. But otherwise, they are moving along. One of the things that we have done for the program for the mentors and preceptors, last year's classes, as Jake and that we explained to you a long time ago, was kind of the guinea pig, because the class that started on Martin Luther King Day is the class that they will nationally accredit. So we used last year as the current class that's graduating in May as a guinea pig to try to figure out how we were going to make things work. So with the class that's testing in May, we assigned them a mentor and a preceptor, and that's who they did all the ride time with. Well, with various issues that came up along the way, that did not seem to be as proficient as we had hoped it was going to be. So with the new class, what we're doing is we're assigning them a mentor, and then they can pick 3 preceptors to ride with for their phase 2, which is to gather all their skills and type. When they do their capstone at the end, they will have their assigned mentor and 1 preceptor out of their group, and that's where they will do their capstone from. Hopefully that will go much more smoothly, and they'll be able to get their stuff done quicker and things around. But what we had to do was we had to design a preceptor program, preceptor/mentor program for our folks specific to the paramedic program, the expectations and the different things like that. We have been doing a preceptor program workshop for everybody for several years. So Jake and Nate have put that together. It is online that all the preceptors and all the mentors that are going to help with the program will have to go online and do. It's about an hour. They'll take a test at the end. They have to pass the test 100%. Gosh, you guys are mean. And then they will get a certificate. So in the essence of this, we are coming here from that and asking REMAC to sanction that program as a 1 credit hour CME so that we can give them credit towards their CMEs.
Be an actionable item.
Yes.
Sounds reasonable to me. Motion? Second? All in favor?
Thank you.
On to medical director?
That would be you.
That would be me acting in Jack's stead. So Jack asked me to talk briefly during our disease-specific stroke certification. The same week, the 2018 AHA-ASA guidelines were updated for stroke. And these are all based on these clinical practice guidelines, whereas in the past, 15, 20 years ago, maybe there was different pieces of literature for disease-specific care. And really what's vogue these days is, bringing together collaboration and developing one set, guidelines. So the big things that have changed is that the window for endovascular therapy has really expanded, now up to 24 hours of last well known. And that's predicated really on 2 trials right now, DAWN and Diffuse 3. So what it means for us is that, we are going to have a larger patient population that would potentially, benefit from care at a facility capable of endovascular therapy. Within the guidelines, and this I think is more applicable to downstate where you have hospitals in very close geographic locations that identify themselves as, comprehensive stroke centers or comprehensive stroke centers with endovascular capability. The guidelines specifically state that there should not be, diversion to one facility over another unless they're, if it's within a 15-minute, time difference. So my interpretation, and docs weigh in, that in our region right now, we would not be diverting away from a primary stroke center to go to a facility with endovascular therapy capability. I think that in the end that would increase our door-to lytic times, IV lytic times. That being said, I've been working with Chris Zammit, who's he's a guy that's ER trained at Cincinnati, then he did a neurocritical fellowship at Mount Sinai. So right now he's at URMC and he's working both in the neurointensive care unit as well as in the ED, and trying to kind of develop an algorithm or protocol so that we're able to identify the right patients with, really large vessel occlusion, so clots in the ICA or in 1 and 2 segment of the middle cerebral artery, trying to identify the correct patients that would benefit from therapy at a tertiary care center, and then keeping patients in our community, at Newark and Clifton and Soldiers and Geneva that wouldn't benefit from any additional therapy. So in doing that, we're kind of thinking about these algorithms, and one of them is trying to identify patients as they come into the ER that really have a balance between sensitivity and specificity for these large vessel occlusions. Now, I'm sure most of you are aware there are pre-hospital screening tools for LVOs. Is there anybody from AMR here?
Hello.
So Chris had told me that a part of Jeremy's and Dr. Vinish's NEC grant is that in Steuben County, they're going to start training AMR to use an LVO screening tool and then bypass some of the southern tier hospitals. Is that live yet?
That is a discussion.
Okay.
The actual training programs hasn't been
Okay.
yet.
Okay.
It will happen.
Any?
I don't have a timeline now.
Okay. Okay. Because in the past, and please anyone weigh in on this, we've discussed these LVO screening tools even at the regionalization of stroke conference last year, and how challenging it would be just because of the how diverse our agencies are, and trying to really have consistency in skill. Any comments? I mean, because if we're going to do it, if that's the advocation as part of this grant, I foresee something like this being pushed in other regions, right, like ours.
In our discussions, in our plans, obviously because it's now us to the closest endovascular center, we'll be utilizing a lot of their medical. So,
yeah.
We'll be working closely with them during this. As far as the training, yes, it's mostly going to be screening tools.
Okay.
It seems like, as a testament or scientific evidence, as a small agency close to a local hospital, with the expanded window It seems like more patients would qualify to go to a Geneva General, a Newark, a Clifton Springs, until there is LVO training out there for all providers. Because at this point, I don't know, and I'm sure most of my people don't know, indicators of LVO.
And there's a variety of LVO pre-hospital screening tools, and, you know, I guess depending on what study you read, some of them have been validated or you know, have been promoted to be better than others. I don't think, so I would argue that we are not at that point in this region right now. I would argue that we would still, based on our geography, bring patients to the closest primary stroke center to receive consideration of intravenous lytic therapy, and then identify those patients that would benefit additionally from endovascular therapy to get to an appropriate facility that has endovascular capability.
Seems like that's where HEMS is going to step in. You know, for the transfers from the local hospitals to tertiary centers.
And Tim, so part of that algorithm, and is anybody from LifeNet here? So it would be either air transport facility or, you know, agency that we work with, would be that there would be an auto launch based on physician you know, evaluation immediately before even a CT scan. So our screening tool for LVO, and this is supported by the CPG, to get the best balance between sensitivity and specificity is an NIH of 10 or greater. So then, you know, we do that quick and dirty NIH. We're now, the process changed for the hospital setting would be concurrent CT, CTA, and those images then sent off for evaluation. But then, you know, the argument is that we would auto launch at the initial point of contact. If you were flying.
And we've been, Dr. Zaman is one of our medical directors.
Yeah.
So we've been working with him on this as well in some of the discussions.
Question is, how many are we really having out here? Has anyone looked at the numbers?
We have. So last year we had about 20% of our get with the guidelines that coded out as stroke had an NIH of 10 or greater on arrival.
Geneva or Geneva?
At Geneva. So I'm sure more to come.
On the red days, when Mercy and LifeNet are on the ground, is this going to change the qualification of the transport? I mean, are we looking at Finger Lakes to do critical care transport?
Well, if they get IV, if they're getting lytics, then we need critical care transport.
Dr. Davidoff wanted to push this EPA down to paramedic level transport.
He wants to push it down to paramedic level transport.
Open it up, make it more readily available.
I would support that.
We have a draft pre-med policy statement.
As long as there's somebody capable of managing an airway.
Yeah.
Because what we have found anecdotally is that whether it's lytics for STEMI or lytics for stroke, and air is not available, we've had significant delays in transport waiting on a critical care team sometimes.
Where is that policy? Is it,
Draft right now.
So-
We're going to review it and then bring it to the main meeting.
okay, so he needs to complete that then and get that out so that we can vote in the main meeting then, wouldn't you? So we'll put that on his list.
Sure. Yeah, I think just in review, you know, the thrombectomy window has significantly gone up, and you know, so we're going to have more patients that will potentially qualify for some type of therapy, requiring additional services by agencies. The other thing I wanted to briefly comment on is that the Mission Lifeline STEMI project is ongoing, and we have done a lot of prior data abstraction, when I say we, Finger Lakes Health, in identifying, you know, our ambulatory STEMI patients and kind of first medical contact to device times in the city, whether it's Rochester General or Strong, and pretty readily identified that we weren't meeting the clinical practice guideline timelines for stem placement or device. So then we kind of shifted back to this paradigm of lytic first, and I know that in working with the Mission Lifeline, a lot of the spoke hospitals have kind of done the same. I know that Thompson did, and some of the Southern Tier hospitals. Within the collaborative protocols right now, the verbiage is I can bring it out, but the reason we don't see a lot of STEMI patients, and I think it's not just we as in Geneva and Soldiers, but I think regionally, is because within the collaborative protocols it states that if your anticipated arrival to a PCI capable hospital from first medical contact, routinely defined as pre-hospital EKG, is 90 minutes or less, then you should divert, right? So that argument doesn't make sense, because the clinical practice guideline for a direct to PCI capable hospital is device in 90 minutes. So if you think that you can get to Strong in 85 minutes, they're not going to get a device in 5 minutes, or RGH or wherever. So the proposal within the Mission Lifeline language right now would be to change, and this is more Melrose, but I told them we have to, this is us too, is that if your anticipated time of arrival would be 60 minutes, and if not, then contact regional or your local medical control. Because I guess what we don't want are people that clearly have contraindications to getting lytics coming to spoke hospitals, and now you're really delaying potential intervention. Thoughts? So from so these are collaborative protocols, though. So I'm I don't know the answer to this. What if this was something that we supported regionally? Is that something we can change?
The region can type the protocol, right?
Yeah, I believe you can do that as an advisory.
Mm-hmm. But does everyone? For me, that's pretty simple. If the clinical practice guideline says you need a device in 90 minutes from first medical contact, and our collaborative protocols say you should, if you think you can get there in arrive in 90 minutes, you should still bypass. That you're not going to get the device, and we've seen that. Dave, 16 calls from Yates County from January 1 of 2016 through the middle of last year for STEMI or suspected STEMI. Not one of those patients got a device in 90 minutes, and most of those were rendezvous with air.
All but one flew.
So we have data from Yates. We don't have it from, again, Ontario or Seneca right now.
Back from Strong in general regarding that. They should have our charts. They should have our times.
Yeah. So we got it back from. This was specifically Strong, but there was a clear, trend. But that would be valuable, I think, is to get, the last 5 to 10, STEMI calls to both facilities, identify first medical contact, and just get the device times. And so then we'll have, we could at least have the data.
Will they give that to us, or does Dr. Davidoff have to ask directly for that?
We probably asked for it, too.
Did they give it to?
They
Okay,
did.
because I know it depends on where you're calling. And
All of ours went to Strong, and they gave it to me.
okay.
Part of their mission is feedback to EMS, so
Right.
they're deliverable there. So we can call
Right.
it Strong in general, too. They've got money.
Dr. Tubman?
I would get as much data as you can, put that together.
Yeah.
And send that on to CMAC or the collaborative committee and see if they will
Okay.
look at that. I'm not sure how they arrived at that time frame.
Mm-hmm.
Maybe they just misread CBG's recommendation.
Yeah, if you arrive at a non-PCI capable hospital, then it's 120 minutes.
Right.
So it doesn't really make a lot of sense.
Well, we can see if we can get that together for May or before then, and then give it, and then discuss it back again in May.
I used to have Dave's data. I don't anymore.
Yeah. But then,
You have it still.
if there's going to be an educational piece to it, we'll have to put that together, because if that's something that we need to bring out to everybody that says you're not going to make it. I mean, Victor Farmington might make it.
Yeah.
That type of situation, and somebody coming across the bridge on 104 could make it to RGH easy enough. But I'm certainly not going to make it, and I'm next door to Dave, so. And I think it's a learning piece that we can do an educational piece with them to explain why.
I can make it to the Arnett when I'm on the backside of Yates County, but going to Rochester, I can't.
So the guy that the lead guy on this, I forget his last name, but he's from Duke, and they've done a lot of the Mission Lifelines in the Northeast, and the number that they identified was 60 minutes, which seems much more reasonable to me.
I think in the educational category that Donna brought up, I feel fairly comfortable in reading 12 lead EKGs, but I think it's something that we need to make sure we have a program in place where the paramedic or the field provider, because in some cases this can be a critical care tech, is comfortable in identifying the indicators of a STEMI. So that we don't get the guy with the pacemaker who goes up for stroke because he had ST elevations.
Yeah, and we saw some over triage when we looked at the data. So I agree. I think we need good feedback loops and re-education on those costs.
But you have to cast the net too, expect a few of those.
Yeah.
Or you're not casting wide enough.
Yeah.
So you always have to accept a few.
But you're also saying that you don't want patients coming that aren't TPA candidates, so that involves a lot of training as well.
Yeah, that's the challenge, is I think creating a quick screening tool. I mean, clearly if somebody, has the, GI bleeding, like as they're having their STEMI, but.
Yeah, but some patients, don't even know.
Yeah.
You know what I'm saying? And that could be create a longer delay than getting the strong 10 minutes later. I don't know. Right, because the GI bleeding would be within 3 months. Is that correct? Major GI bleeding within 3 months.
Yeah, I mean the new Alteplase, the contraindicated, it's actually new. It's now within 21 days, but I believe that for the Tenecteplase, it's still within 3 months. So the Tenecteplase, the contraindications and relative ones are still much less now than the vast literature on the new CPGs, but for stroke, for Alteplase. But it's still a fair number of things that you have to kind of check through and off. So. So I don't think that we're ready to, be live, but I think it's something that we need to consider if we're going to look at the evidence and look at the guidelines and, and practice. And I think we do still need some data.
More to follow.
Thanks. Yeah.
So
RSI, RSA?
Yeah. So the committee will be meeting on April 12th at 9 o'clock at the New Finger Lakes Ambulance. This will be more to discuss more administrative things than actual protocols. This is to discuss the class and credentialing from providers from other regions, specifically in LRMs. Also some other housekeeping things like policies, redoing the policies, especially with call volume numbers, how many calls you have to do, QA and all that stuff.
Ed as well.
Yeah, and continuing ed as well. We've been very lax on the continuing ed part. We made it supposed to be 12 hours a year, and the respective RSI agencies are supposed to share the hosting and the teaching and the creation of the lesson plan for that training. We've been very lax with that, and that's something that we hope to change.
All right, again, time and date on the meeting at
April 12th at 0900 hours.
14 Main Street.
Yes.
Ross, I would believe once that meeting is done, we can forward that information on.
Keep that in queue so that they know to send me.
Yep. Because they've asked, Dr. Cushman asked for some information on our program. He and Dr. Davidoff have been in communications on the going across, so I think once we get that set at that meeting, we can forward that.
Yes.
We can forward that criteria to them because they're asking what our...
I have Jeremy's email, so I can add him and Ross to it.
Okay.
I believe that's the Melrose REMAX simply waiting on our procedures and training.
Yes.
To vote on.
Is that what it is?
Yeah.
Yes.
I mean, they're all for it, they just need to
They
see
just
what.
want everybody.
That's what I'm saying.
Is this for calling orders or for?
Yeah.
Yes.
Understandable.
Okay.
So I think once that 412 meeting is done and we've set that, then we need to forward that to them.
Yeah. RSI agencies.
To here or?
All ours.
Nope, Finger Lakes ambulance. All RSI agencies need to attend.
Okay, advanced practice?
We met beginning of the month. We're finishing up the tag on the regional documentation standard. We'll have more for the May meeting. There's no reason that won't be wrapped up by May, as well as the tag on a regional clearance process. A couple things that we're asking the REMAC for maybe some policy statements on, policy advisory statements, excuse me, would be the use of rocuronium versus succinylcholine for inductions due to shortage. The collaborative protocol says vecuronium may be used for induction if rocuronium is contraindicated. I mean, my stretching the understanding of that would be if you don't have succinylcholine, that it's contraindicated and you can proceed to vecuronium. But we would like something from the REMAC on that, as well as the reduced use of routine normal saline infusions. You know, you start a line, you hang a bag KBO. We all know the shortage of saline is an issue right now. We'd like to see something from the REMAC as a policy statement on reserving your saline infusions for those patients that are truly hypotensive or in some kind of hemodynamic compromise. You know, your distributed cardiogenic and hypovolemic shock folks. The KBO is really a waste of a valuable resource that we're holding at the hearing. And lastly would be a recommendation for dilution of dexamethasone injections in 10 milliliters of normal saline as opposed to a straight push of dexamethasone as is currently allowed in the verbiage of the collaborative. There's no indication that it should be diluted, so our concern is there may be providers that are following the protocol and just drawing up, the dexamethasone straight and administering it IV push as opposed to diluting it. So we're looking for a little bit of verbiage from the committee on that. We'll be meeting again the first Wednesday in May, and hopefully wrapping up those two tags and bringing the progress of those tags to the REMAC meeting in May for the approval from this body on those two recommendations. That's all we've got from the advanced practice meeting.
Very good. Mercy Flight?
We'll be having our annual education day. There's flyers going around. We asked you to share those with your colleagues. June 1st, Finger Lakes Gaming and Racetrack. Same setup, 6 hours of continuing education and buffet, all you can eat for lunch. So hopefully we get our registration is open on our website and on Facebook as well. So certainly encourage people to sign up early. Unless you have anything, Tim, that's really all we have.
LifeNet Guthrie have representation there. Finger Lakes? Any other committees?
Any other agencies?
Okay. Old business. Collaborative protocols.
I think they touched on a few things we got for questions for that.
We still have physician credentialing on here.
Dr. Davidoff is reviewing the Melrose one because he's got to do whatever changes he wants to do and get with Ben. So hopefully that will be done for the May so he can move forward with that. What's that?
The Fornall issue, where that went?
That's at the
Still
state.
working on that?
State. That's at the state.
level.
Yeah, they didn't have quorum at their last meeting, so
What was the issue?
Can we give it without calling?
Currently, it's an absolute online
Yeah.
instead of a standing order.
If there is to be a change to the STEMI protocol that we were discussing, hopefully there will be a quorum at the May meeting. The thought would be to discuss it possibly with the collaborative folks, the the night prior and see if it could get changed. We'll see how that is reception. Yeah, we'd see how receptive Dr. Daly and his folks are to that. Certainly, if we had the data to take up there, we could certainly make a push for it.
At the May
State meeting.
Which, okay, I think okay, so I'm going to go to that with you guys, Jack. Okay.
May
15th and 16th.
So if agencies that are applicable here today, are able to get data, that would be helpful.
So we do with the region and pass that along to the
Or STEMs.
For STEMI. Just for STEMs. So it's really first medical contact, i.e. pre-hospital EKG to device time. That's really all we need. And then maybe mode of transport. So
Would be a place where we can revisit the idea of telemetry for 12-lead EKG. It's one thing that I look at it and say, gee, that's an inferior wall STEMI. It would be an awful lot better if I could send it to you and you said, oh my goodness, that's an inferior wall STEMI. Go to Rochester. Right now, we don't have telemetry in place.
I know this has been brought up before. Do any of the other hospitals have online ability to review?
No, but with
Syracuse hospitals have it.
Syracuse and CMC would be the other closest to the medical.
with the use of the First 911 app, you can actually send a picture of the EKG and they can view it and be able to respond back to the provider right through your phone. And I have done that in Rochester.
That's HIPAA compliant.
Yeah.
So we as in the ED docs would need to get that on the app on their phone?
Your hospital gets it on an actual computer. So as a provider, I'm using my phone.
Yeah.
It goes to a computer at the hospital so you can see it full size.
Something the hospital purchases?
the NC department of your hospital.
Free. It's free.
It's free. What is it called again?
It's free for agencies. I believe the hospitals are paying.
BRYX.
BRYX?
Bricks. I know in Melrose they use it a lot for generic notifications, plus also STEMI notifications. I know that's something that
Trauma.
Yeah, you can notify the hospital.
We're using it for trauma.
It's something that the Advanced Practice Committee is looking at. It's looking at the number of proper notifications and whether proper notifications, meaning did you call STEMI. We're also looking at on another angle if you've been diverted and reasons why you've been diverted. So that's something that probably could help a little bit.
Great.
I'm just not sure what hospitals have it around here.
It's strong.
Strong.
Yeah, I don't think any of the local ones are yet.
Okay, so did we talk about the annual conference?
We did, we talked about that. Unless, again, anybody has any topics or anything, if you shoot them to me so we can start putting them in the packet or the pocket of things to start putting together.
And then a new website?
The website's basically done. We give it to today the county committee to look at, and then we'll bring it up to full council next week for final approval. We'll be putting that up online here in the next couple weeks.
Then the last thing I have is I attended a RGH EMS meeting a couple weeks ago and they are now obviously a level 3 trauma hospital, but they are doing a, no, not level. Heading for what? They're heading for what then?
They're building an acute care surgery program.
Okay.
But they don't have a timeline for verification or delivery.
Okay, then I misspoke, I'm sorry, but they're doing a grid on what trauma can go to RGH? Because they're seeing some trauma that should be going to Strong?
I think we should, EMS agencies continue to follow the CDC field guidelines.
Right, and that's what he was...
Transport. So I don't think it's a new grid, it's the same CDC field triage packages.
Just out of curiosity, the CDC guidelines that are on the Collaborative Protocol app are from many years ago. Is there any update?
No.
It's the same ones. I mean, they are reflective of the most recent, like, ATLS stuff, but it's surprising that there's not a new reference. Yeah. Anything else? Motion to adjourn?